vessel tortuosity, risk of catheter jumping into aneurysm exists, so catheter pullback method is better. Wide neck type is difficult to treat with simple coil insertion due to the risk of coil protrusion from aneurysmal neck. As for morphological parameter, dome to neck ratio or aspect ratio are widely used. The most common definition of wide neck type is dome to neck ratio less than 2 or neck diameter of 4 mm or more. When we do coil embolization, working projection is very important. Working projection is a view we can recognize border line between aneurysmal neck and parent artery. Left projection is good, but right one is not good, because we cannot judge whether coils in this part are in the aneurysm or parent artery. Left projection is good, and the right one is not good. When we select the framing coil, coil size is average diameter of XYZ. We can use 3D shape and helical shape. In this case, coil selection is too small for aneurysmal diameter. On final angiogram, there are some space outside of the coil mass. This is risk of recanalization. On the other hand, coil loops are good contact with aneurysmal wall. In this case, the aneurysm is occluded with coils completely. How many coils are needed for obliteration of the aneurysm? Volume embolization ratio is good index for setting goal, finishing point. If you use lambda centimeter of 10 coils, VER can be calculated by this formula. More than 20% would be needed for adequate obliteration. Coil loops movement is different according to the catheter position. Standard catheter position is the center or proximal 1/3 of the aneurysm. At this position, coil loops moves concentrically. When catheter tip is deeper side, dome position, coil loops come to the neck side. On the other hand, catheter tip is around the neck, loops go to dome side. So we can control coil loops by catheter maneuver. This case is MCA unruptured aneurysm. The shape is wide neck. Initially, coil loops are coming to the parent artery, so I changed the catheter tip position out of the neck. At this position, coil loops go into dome, and I could make coil frame with simple technique. Wide neck type and irregular shape are difficult to treat with simple coil insertion. So we need to use adjunctive techniques in such a case. Balloon-assisted technique can seal the aneurysmal neck. It is also useful for getting hemostasis at intra-procedural rupture. Vessel shift in distal are sometimes disadvantage. This case is right IC paraclinoid wide neck type aneurysm. Coils are inserted without any protrusion by balloon-assisted technique. Balloon assist can also contribute to microcatheter stability. Complete obliteration was achieved. Double catheter technique can make coil frame with two coils. Minimum vessel shift is a benefit of this technique, but stability of microcatheter in the aneurysm is needed for coil loop control. This case is unruptured IC paracrinoid aneurysm. The shape was irregular like a clover, so coil framing is very difficult. Double catheter technique is useful for such a multilobulated aneurysm. Two microcatheters were inserted into the aneurysm. The first coil was inserted but still unstable. A second coil was inserted from the other catheter before detachment of the first coil. Stable frame was made with two coils and coil embolization was achieved. Advantage of double catheter technique is that we can decide to detach the first coil or not after two coils insertion. Stent is the most stable scaffold, but dual antiplatelet therapy is needed. These are neck bridge stents approved in Japan. Neck bridge stents are divided into two types, braided stent and laser cut stent. Braided stent is made of wire mesh. Laser cut stent is made of metal pipe. A braided stent has higher metal coverage rate, so flow diverting effect can be expected. On the other hand, positioning and deployment of laser cut stent are very easy comparing with braided stents. We have to select the best stent in each situation. This case is unruptured ACOM aneurysm. Coils were inserted with double catheter technique, and one coil loop protruded to left A2. So neuroform atlas laser cut stent was deployed from left A2 to right A1. Positioning and deployment are very easy. Neuroform atlas is very soft and having good conformability. Vessel shift is minimal. Six-month follow-up angiogram demonstrating complete obliteration of the aneurysm. This case is right vertebral artery unruptured fusiform aneurysm suffering from facial spasm due to mass effect of the aneurysm. I was afraid of worsening of facial spasm due to coil mass, so I did Elvis blue stenting with a small amount of coil embolization. Of course, flow diverter is a good option. 3 months follow-up angiogram demonstrated complete obliteration. This is because Elvis braided stent has a flow dividing effect. I introduced 3 adjunctive techniques. These techniques should be used properly in each situation. Next topic is troubleshooting. What should we do? There are some tips for bailout of intra-procedural rupture. The most important thing is to notice the fact. Please don't pull back the coil and catheter. This is because the perforation is closed by coil or microcatheter. If you pull them back, extravasation will occur. What you should do at first is blood pressure control. Balloon catheter is very useful for temporary occlusion of aneurysmal flow. If temporary hemostasis cannot be achieved, protamine reversal should be done, and you should do further coil insertion to get hemostasis. If the tip of microcatheter is intra-aneurysmal with simple coil perforation, like this, further coil insertion outside to inside of the aneurysm is useful. Perforation hole is sandwiched with coils. But if the tip of microcatheter is out of the aneurysm, perforation hole is large, so we need second catheter. Further coil insertion from second catheter is better. This is left IC anterior choroidal artery ruptured aneurysm. It's very irregular shape with multiple blebs. This is a working projection. We can see aneurysmal neck and the orifice of anterior choroidal artery. First coil, Galaxy complex filled 6x15 was inserted with balloon-assisted technique. When I was inserting second coil, coil loops went out of the aneurysm, like this. I inflated the balloon more to seal the aneurysmal neck. The very important thing is that only coil loop perforated the aneurysmal wall, and the tip of microcatheter is in the aneurysm. So I continued coil insertion in the subarachnoid space, and then coil loops come back into the aneurysm. In this way, the hole was sandwiched with coils. Final angiogram demonstrated complete obliteration of the aneurysm. She discharged without any neurological deficit. This slide is about peri-procedural antithrombotic therapy. When we treat unruptured aneurysm, dual antiplatelet therapy DAPT starts at least 2 weeks before the embolization. Hyperresponder for clopidogrel is frequent in Asian people. We do platelet function testing before treatment, and we do intra-procedural heparinization. As for ruptured aneurysm, we do only intra-procedural systemic heparinization just after sheath introduction. These are essential points of aneurysmal coiling. Peri-procedural antiplatelet therapy, appropriate working projection for neck detection, microcatheter stability in the aneurysm, appropriate coil selection, microcatheter maneuver for coil loops control, application of adjunctive techniques, bailout of aneurysmal rupture, and thrombus formation. Thank you very much. ありがとうございました。